All right. So, Sam, thank you so much for joining us on the You're Not Alone podcast today. I am super excited to have you on. And before we hit record, we had a little chance to get to know each other. And I feel that your energy and everything just feels, it feels right for this episode right now. Not just right, okay? Using a little OCD joke right there. But I'm really excited to jump into a couple topics that are near and dear to your heart. Because I think that they're very important and I'm very curious to hear more about them. But before we jump into that, can you walk us through your journey of living with and then being diagnosed with OCD?
I think I had a pretty interesting trajectory in terms of OCD. So before I even knew that I had OCD, I was never diagnosed with it. I was diagnosed with anxiety. Then I was diagnosed with some depression, which was kind of a lot of people experience depression kind of comorbid with OCD almost as a reaction to pretty severe OCD episodes and then the fatigue afterwards.
Yes.
So that was a lot of my experience. And I went to some standard CBT therapy, did a lot of cognitive therapy kind of work, and it helped to some degree, but I was still struggling and didn't have a name for it. I went to grad school. I took graduate level classes and where OCD was covered. And even in grad school, the education has not really caught up to where OCD actually is. And I still understood it to be compulsive hand washing or, counting things, that those kinds of things that are certainly OCD, but are not really representative of most types of OCD, which I feel like, yeah.
I don't want to interrupt you, but how recent was that? How recent was grad school and the information being
within
outdated?
The last 10 years?
Wow.
When did I graduate? I probably only graduated like, oh my gosh, the math is hard because the pandemic kind of clouded everything.
Hey,
but
those are the blurry years.
I believe, to the best of my pandemic-affected memory, that I graduated kind of right before it started. So
okay,
how long has that been? Only like 3 years or so.
So you graduated. You graduated right before the pandemic hit.
Yeah,
and the information was still that outdated.
The information in grad school, I was not taught. Well, so it's a little bit of a twofold story. In grad school, through the kind of general classes, I was not taught about purely obsessional types of themes of OCD. It was really, I just absorbed the stereotype of it all.
Yeah.
I had in grad school, each year you have to do clinical rotations at different placements to gain a diversity of experiences. And there was one peer of mine who said, "Hey Sam, I think you'd really enjoy doing ERP as a therapist."
Yeah.
I'm a pretty outgoing person. I like to work with a lot of energy in the room, and they just perceived that ERP would be a type of therapy that I would have a lot of fun and enjoyment conducting.
Yes.
So I heard about it. I said, "Oh, that sounds great," especially because, and this might be like a theme of what we talk about, the work that I do, I always want to hold to the highest standard of evidence-based work. And I want to guarantee the folks that I work with that they have the best possible statistical chance of getting better. And ERP for things like OCD is one of the most empirically supported and highest effectiveness, rate-wise, treatments that have kind of ever been developed for disorders. So I was really attracted to the success rate behind something like that. So I said, yeah, let's do it. Let's go all in. I did an externship at Northwell Health under Anthony Pinto. He's an expert in perfectionism and OCPD as well as OCD. He's a brilliant scholar and clinician.
What's his name?
Anthony Pinto.
Okay.
He's over in Glen Oaks. He runs an OCD center along with John Chrisman, who's the psychiatrist there. Both of them are absolute brilliant minds.
Wow.
And it was there that I learned about relationship OCD, which is, my best friend, my bread and butter.
Yes.
Been my roommate in my brain for most of my life, as I later learned. and everything like really clicked of, oh my goodness, like this is me. So I was attracted to the treatment of it before I even knew that I had the diagnosis. And then from there, it was like, oh, it's what's that one movie where like he's making everything up because the board's behind him and the person pieces together all the lies at the end of it.
I don't remember. It's not going to come to me.
It's not Usual Suspects, but something like that. I started to kind of piece together like, oh my goodness, every time that I've been anxious in my life, it's been around, will I find the perfect person? Every time I've been depressed in my life, it's been around, I bet I won't find the perfect person. And it really kind of made a lot of things make sense. And that's kind of where my OCD journey really kind of started.
Yeah, and that you answered a question for me that I had there at the end, because I was curious about the severity of the anxiety and depression that you had attached to the relationship OCD thoughts. And because you said a key word to me that really stuck out, which was the fatigue after a depressive episode.
Sure.
Can you explain that? I know what I think that means, but I'm so curious to hear what that means to you.
So the way that I conceptualize it, there's two main patterns, or at least I've conceptualized two main patterns of the ways that OCD can either interact or be comorbid with depression. One is to directly answer that question. Depression that comes after really big OCD spikes. And that depression can be a number of things, either just I am so burnt out from having so much OCD. I'm just like neurophysiologically kind of fatigued. My brain has been kind of pumping all of this adrenaline, and here's the crash.
Yeah.
It can be kind of this hopelessness or kind of depressed perspective on what just happened. Oh my goodness, this last month in my life, like looking back now that like the OCD has kind of like reduced in severity or intensity, I feel like I was just like almost psychotic for like a month, and it was so disruptive. I can't believe that I'm the type of person that has something like this. This is so depressing that this might happen in the future, and having those depressive thoughts. So that could be depression, like that could come after OCD. Sometimes it can be more of a mixed bag, where depression can be a compulsion from OCD, where we can feel so much distress at the uncertainty of a given topic that the brain, as a defense, says, no, you don't have to experience this heightened pain of uncertainty. Let's just shut everything down. Let's just conclude that everything is screwed. Because if I conclude that everything is screwed, at least there's certainty.
Yeah.
And you have to kind of sit with that depression, but you don't have to wrestle with the fact that everything might also be okay, which is just painful to not know, like, you know, where are things going?
Yeah.
So sometimes we could kind of surreptitiously, not so consciously, but we could lean into depression to kind of numb ourselves from feeling intense anxiety and to escape from the OCD.
So that's really interesting. I experienced depression from the intrusive thoughts that I was experiencing. They were ego dystonic. I felt separate from them. And then I always say I felt like I broke my own heart, because it was a deterioration of my identity for the thoughts that I struggled with: sexual orientation, POCD, harm OCD. I've had the relationship OCD sprinkled in there, health, and how does one, it's interesting, I've actually never heard anyone say depression as a compulsion. How does one untangle themselves from something like that?
So when the depression is compulsion, you'll find this oftentimes when, I started to become most aware of this when conducting exposures with clients. And occasionally when doing an exposure with a client, the client would start to become kind of tearful and start to lean into oh my God, it is true, right? I am a pedophile. Oh, I am actually gay. Oh my God, like I bet this is true, and I'm just faking myself right now, and this is just a total sham, and I shouldn't be in therapy. And like I feel like I'm realizing all of this right now. It's pretty common.
You just described me. Well, and it's everybody. It's a common reaction. And I remember in numerous sessions I cried, and it I felt heartbroken because I was convinced.
Right. So it's exactly that experience. That experience is definitely a pattern within the OCD community. Not everyone responds in that way, but there's many people that do enough that it's, to me, clearly an established pattern. And it became evident to me that was another defense mechanism from the brain, right? To not sit with the uncertainty, to make a depressive conclusion. It's almost the same function as saying, know what, this is all OCD, I'm totally fine. And reassuring yourself. It's the same exact thing, but in the other direction. You're saying, you know what, everything's terrible. And it's just another way to not sit with it. So the way that's been very helpful for a number of people that have that is to start to treat those depressive kind of symptoms that can feel more like realizations than questions, right? Sometimes we could have intrusive thoughts that is, am I gay? Sometimes we could have intrusive thoughts that is, oh, I am gay. I've just realized this. Right?
Yeah. Yep.
And to treat those with the same irrelevance that you would a anxious laden question version of an intrusive thought. To say, okay, my brain just said, I finally realized that I'm gay. My brain just said, this is the moment. And just like with the body of like, oh my God, I feel this heightened anxiety. Does that mean that something's wrong?
Yeah.
And you could ascribe a relevance to that through, all of the skills. The same thing with the depression. Okay, my body is having this kind of doom and gloom feeling that feels like it's finally concluded this feared outcome. I'm going to let that happen. I'm going to make space for it. I'm going to use my ERP or ACT skills, notice the depressive thoughts and the feelings and let them be, and have that same attitude of, yes, maybe those are true. Maybe I should indulge the depression right now.
Yeah.
Maybe that is a sign that my body just knows something that my brain is not trying to accept. And once someone has a relationship with that, it often responds the same way when someone has an open, accepting relationship of the anxiety, that not necessarily can you guarantee that it'll go away, but it definitely neutralizes it and dramatically reduces the chance that it's going to intensify or stay for a very long period of time.
That was a really thorough explanation, and that was really helpful. And I think that you touched on a lot of good points. One thing is like the whole idea of like, this is just OCD, like that can become a compulsion, right? A way of giving yourself certainty. The other thing that I thought about too is the depression as a feeling being a signaler that, oh, if I have a pedophilia intrusive thought and I feel depressed, that must mean that I'm not a pedophile. And so,
or the other way around, right? Making any sort of conclusion around it. Oh, if I have this intrusive thought and I feel depressed, maybe that means that maybe that's my brain and my body saying, oh, like that's the truth. So now you should be depressed, right? It's interpreting anything that your brain is saying and saying, now I have an answer.
You mentioned one thing about an ERP or ACT response. I know what ERP looks and feels like. What does an ACT response look like when dealing with intrusive thoughts?
ACT is way more varied in its suggested responses than ERP, because an ERP response is really an RP response, and an RP response prevention, it's almost defined by its negative. It's not that you're responding; it's response prevention. You're just not
doing nothing.
Responding. Yeah,
right.
With ACT, ACT's style is it's really kind of a shotgun approach to some extent, in which there are literally hundreds of different suggested exercises of ways of viewing your thoughts differently or changing your relationship with your thoughts, whether it's singing the intrusive thought or it is adding a character or personality to the voice of the intrusive thought, writing it down and holding it kind of far away from you so you can see that one sentence is surrounded by many different things. There's a lot of different things, some of which seem kind of campy or sticky and some of which are very poignant and insightful. And it's really about trying on a bunch of different hats and seeing what's helpful for you. But at its core, ERP and ACT are both successful because they get at the same thing, which is a little bit of like a mindfulness kind of vibe of just being able to notice that your brain is producing what your brain is producing and not attaching to it.
Right. Almost that the thoughts, it's junk content. It's like an annoying Instagram influencer that has nothing valuable to say on social media, but they're squawking the loudest, trying to get your attention to engage with the content. And they're going to say whatever they can to get you to pay attention, right? To buy their product or their service or whatever, but it's all junk. None of it's actually going to be helpful. And so that's sort of the analogy that I use, but I think that what you highlighted is really, really important for listeners because they both get at the same thing. And, like one thing that was helpful for me, and that's why I wanted to ask, was like turning my OCD into a character.
Sure.
Like you referenced, and making them separate, making him, he's a him, but he's separate from me. He's his own guy. He does his own shit. It has nothing to do with me. And he kind of runs on his own loop. And that character building has been helpful for me. But what I love is this buffet of options, it feels like, that you've laid out in terms of trying out different things. Now, of course, ERP being the gold standard, to your point, empirical data to support that it is very effective. And I actually wanted to circle back to that because you seem like somebody who's really plugged in the space. We have ERP. Do you know when ERP became the gold standard? Like when it was its inception and when it was created, out of curiosity?
Exposure started from like Edna Foa, and that was way back when.
Okay.
I'm not exactly kind of sure when, but she's someone who was like, born in the 30s kind of kind of thing we're talking about. So exposure has been around for forever. In terms of when it became adapted for OCD and then when it became the gold standard, something becomes kind of a gold standard because it accrues like years and years of evidence, and then it's compared to many kind of different things. So I'm not exactly sure of the historical timeline and its trajectory. But I know that it has been kind of well established to be the way that you treat OCD. I would guess for at least 30 years, maybe 40 years, but that's an uneducated guess.
Yeah. Well, I definitely wouldn't call you uneducated. You know what you're talking about. But
well, in
yes,
that aspect, yeah.
That's fair. Because one thing that comes to mind is just like, oh, well, thank God I was born in the last 3 decades. I'm 31. So, it's like, if this has only been around for 30 to 40 years, my heart breaks for just all of humanity that had to suffer with OCD before there was an organized treatment. And I would say ERP it's hard. People, and I'm very careful with how I label, like I never call a single thought that I have horrible, because I feel that signals to my brain that one thought's good, one thought's bad. So I'm saying that, I say that ERP is hard just to validate the listener. I don't have to do as much formal ERP now. I do micro exposures as they pop up. But I know for a lot of people, it's difficult to do ERP. And this is one thing that you specialize in, which is working with individuals that are not responding to treatment resistant. Can you just give us the whole breakdown on why you think that happens, how to respond to that, what to do differently? I'm genuinely very curious.
Sure. Maybe I could give you 2 different options in terms of level of depth, and you could let me know which would be appropriate here.
Yep.
One is why sometimes ERP doesn't work.
Yep.
And then the other is why oftentimes non-ERP things don't work. And then in addition, even why ERP itself doesn't work.
Ooh, that's a great breakdown. So the first one was why sometimes ERP doesn't work. then there was why sometimes other talk therapies don't work.
Yeah.
And then
like starting from that more basic level of why do we choose ERP over talk therapy or cognitive therapy or psychodynamic, generally speaking, or the more kind of nuanced level of, what could be improved from ERP, or both.
Let's do both. I like that.
So starting from like the more general level, like, why does the field gravitate towards ERP more than other things? Everything that I say here can be taken with a grain of salt, because everything that I'm going to come off as disparaging here does have some evidence base towards treating OCD. I've seen studies that show that cognitive therapy works with OCD. There's a lot of people that are interested in how psychodynamic can apply to OCD and stuff like that.
Can I pause you?
Say that again?
Can I pause you for 1 second?
Yeah.
Psychodynamic. Could you explain that?
Okay. So psychodynamic is, if you're going to divide all of therapy into two different schools of thought, you'd probably make the division around, on the one side, psychoanalytic and psychodynamic, and then on the other side, cognitive behavioral therapy and its related treatments.
Okay.
Psychoanalytic, psychodynamic, and this is also where I'm stepping a little out of my expertise. I was dual trained in grad school, but it goes much deeper than a few classes in grad school. But psychoanalytic, psychodynamic is where people that have not heard of a lot of therapy might go into stereotypes. It's Freud. Freud was psychoanalytic, and then his student Carl Jung developed psychodynamic that kind of criticized some of his stuff and kept some of the others, et cetera, et cetera. From my understanding of psychodynamic psychoanalytic, well, generally you're not really going to find psychoanalysts that frequently. Psychodynamic clinicians are, that's the part of it that has been modernized. There are still psychoanalysts, but it's a minority of that kind of spectrum of the population. Okay. And generally, again, from my more layman's understanding of it, it's meant to kind of explore on a quote unquote deeper level where a lot of these thoughts are coming from, looking back into childhood and associations that you've made, stereotypically your relationship with your parents, et cetera, et cetera. And then saying that everything that you're experiencing in the modern day is really tied to those origins, and that through understanding those origins, you can achieve some catharsis and some level of insight that can help you kind of integrate and to move on in the present moment.
That was very helpful. It sort of takes me to the laying down on the couch with that old school model that, believe it or not, a lot of people still think that is.
I did that I didn't do it as a therapist. I did it as a patient because I wanted to experience it. I stopped. I'll tell this brief story of what really just was the nail in the coffin. So much of it to my subjective experience was the therapist had the leave to just interpret anything that I was saying and to kind of craft a narrative from it. Yeah, that was just based on their own kind of gut feelings or their instincts or things like that. And at one session, I was doing it twice a week, lying down on the couch, dream analysis. Yeah. I had a dream where I'm in New York, and in the subway system, there's two different levels sometimes of depth of the system. And I said, I had a dream that me and you were in the subway system. We were waiting for the 2-3, and I wanted to go down. I wanted to go deeper into the subway system to take the 7, and you didn't want to come with me. What are your thoughts on that? And she's like, you know what? I think in this dream, I'm you and you're me. And I'm asking you to come down in the depths, and you're afraid. And that's what the dream means.
She tried to flip it on you.
It tried to completely flip it and say the obvious answer is and at that point I was like, I'm done, because my clinical orientation is I want something that is evidence-based, that is rational, that is testable and can be really tested and that seems so based off of just interpretation to me.
Totally.
That's psychodynamic, psychoanalytic. And then if we're going to really broadly divide a lot of cognitive behavioral therapy, CBT, you might divide it into cognitive therapies and behavioral therapies. And then in the last 20 years, mindfulness-based therapies, that's DBT and ACT. Why have we gravitated towards the behavioral therapies like ERP or the mindful therapies like ACT, and not done the psychodynamic, psychoanalytic, and not as much the cognitive? With the psychodynamic and psychoanalytic, a lot of it is, where the psychodynamic could really mess people up is that some clinicians that use that orientation say that every thought has a lot of meaning to it. And we really need to explore and understand what is the meaning behind that thought. Right. And immediately, as someone with OCD, you probably already get why
I'm
that
triggered.
Could be,
that would be dangerous.
Totally, like not even unhelpful, but maladaptive and harmful.
Absolutely.
For someone with OCD. It's just kind of obsessing over and over, and it's everyone's greatest fear that this means something about me, right?
Yeah.
With cognitive therapy, what we're trying to do is we're trying to rationally dispute the fear. This is not logical. This is the evidence for this. This is the evidence against it. Okay, now you've made your rational conclusion. Yep. Likewise, anyone with OCD will be able to tell you they've done that a million times.
Yes.
And it is not a problem about making a rational best guess, but it's about adhering to that in the face of a broken alarm system that can feel very compelling.
Yes.
So what that leaves us with is ERP or mindfulness-based cognitive behavioral therapies that still operate off the same principle of let's change our relationship with thoughts. All of that said, ERP, as it is very commonly used, is not as tied to modern evidence as it could be. And ERP has been almost secretly, because there's such a huge gap between research and practice, where there's often a delay of at least 10-15 years of something having good research behind it and clinicians really knowing. Because once you're out of grad school, unless you're really passionate about it, you are practicing for the next 40 years, mostly based off of what you learned 40 years ago, right?
Wow.
And unless you got expert training in it, those trainers, then you're training people on the outdated thing. And it's really hard to bridge that gap between research and practice.
Wow.
That phenomenon, to some extent, to my belief, applies to how a lot of people are conducting ERP. There's an outdated model and a model that has been very empirically established over the course of the last since at least 2008, I would say.
Okay.
Of how to do ERP. And this goes to answering that second question of why is ERP sometimes not successful?
Right.
The answer I'm going to replace it with doesn't make ERP successful 100% of the time, but I think it dramatically improves the chances.
And can you share the outdated model too, so we know?
Yeah, absolutely.
Okay.
So with the outdated model, that was called kind of the emotion processing model. I think colloquially we could understand it as kind of a habituation-based model. The habituation-based model says that exposures are medication. Take 2 exposures and your OCD is going to die down, right? If you do these exposures, the more you do them, the more that you will habituate, a term that means get used to, the more that you will habituate to the fears. And by doing enough exposures, your brain is going to create this new association with them, that there's nothing threatening, and the OCD will die down and it'll go away. We'll shake hands, you're cured, goodbye.
Yes.
Right.
Yep.
That's not really the experience of OCD. And also, according to the evidence, that's not really how habituation works. even
Yeah.
though we kind of conceptualized it to work in that way. A number of studies have shown that habituation isn't related to treatment outcome. So if you measure how much someone is habituating to their OCD theme, that's not really related to how much better they get. So even if they do habituate, it's kind of an irrelevant variable. Complete habituation is not often possible, right? We look at OCD, the more modern look is that it's part of your brain, right? We're looking to, this is a spoiler alert for the updated model, but we're more working to install like a filter system rather than lobotomize you.
Yeah.
So to give you a way to kind of relate skillfully to those symptoms over time, rather than promise that we can kind of delete this part of your brain.
Yeah. Never have an intrusive thought ever again.
Exactly. Everyone with OCD's dream, but unfortunately, it's going to be much more practical to design therapy around reality than a fantasy.
Yes, totally agree. And that goal is a trap.
Yes.
I know people that are a decade and a half into their OCD journey and more or less in the same spot because they can't let go of this. That's why I'm so interested in the treatment resistant, because they can't even let go of the idea of never having an intrusive thought again. But I don't want to cut you off. So
no, you're absolutely contributing, because that's exactly what all of this is about. I mean, and furthermore to that point, even if somebody does habituate to something, their theme often switches.
Yes.
A lot of times, actually, session 3 or 4, when I'm working with a client and maybe, they're a real go-getter client and their symptoms have started to reduce, they're going all in. I say, okay, now is the time that I want you to be mindful in the next few weeks, because I'm going to predict that your OCD theme is going to switch.
Oh, that's clever. That's really clever.
Yeah, because it so often happens.
Yeah, that's so helpful for the that you do that for your patients.
Yes. Yeah. Because it takes the surprise out of it. And it also stops us from playing a game of whack-a-mole.
Exactly.
But I'm getting a little bit ahead of myself, because I'll explain the newer kind of model and why it does work. So to wrap up like this older model, so it was saying that exposures of the medication, you do exposures and you will be able to get rid of your OCD. The strange thing is that even though like having a conversation and explaining the theoretical underpinnings behind the models, like a lot of people with OCD will already be able to understand that's not the way it works. And like, I get that that's not going to happen. I've done my research. I've done my obsessive Googling, like every good OCD person has done.
That's right. Badge of honor.
100%. I've been there too. ERP, even during that time, was still the gold standard. It was still the most effective thing. So there's still something that's very effective about ERP. It's just that folks hypothesized that it was effective for the wrong reasons. And by understanding why it is effective, because even in done that way, it still has pretty good rates. Understanding what are the actual therapeutic mechanisms and components of ERP can help us kind of hone it and fine craft it to a way that is kind of more practical. So then along comes the inhibitory learning theory model. So now we're comparing two models, the emotion processing model that really has to do a lot with habituation, and the inhibitory learning theory model, which is started back in 2008. John Abramowitz, brilliant mind, still doing tons of work on it.
He was one of my therapists.
No way.
Yeah.
Oh man, how
out of UNC, right? Out of North Carolina. He's out of North Carolina.
I believe so.
Well, he was back then. And I think he was either at the Duke office or the UNC. He was doing research out of one of the universities.
How was that experience?
Great.
Amazing.
I came to him with pedophilia OCD thoughts, and I was a mess. I mean, I thought I was, and that's the funny part that you bring up, and that's why I think it's so important that you speak to your clients about this. Is I initially had sexual orientation OCD, and that was like the first one that I started with, and it was the game of whack-a-mole. Like as soon as I had sort of started to knock down some of those thoughts, boom, pedophilia just came to the top. And yeah, I mean, I cried in front of him very hard our first session, because I was convinced. And I was
Yeah.
suicidal. I was depressed. I
Right.
thought that I deserved to die. Like, it was all of it. Yeah. And he helped me.
Yeah.
I mean, it was great. I got to shake his hand a few years back at the IOCDF conference.
That's amazing.
So it was sort of that wholesome full circle moment. But yeah, anyways, not to cut you off, the inhibitory learning model.
You lucked out. He's brilliant, and all of this is really kind of goes credited primarily to him. That I'm just going to be kind of regurgitating his brilliance here. The inhibitory learning theory is it's inhibitory learning, right? It's in learning, like the science behind how do we learn. We have also long since established that we can't delete old associations and learn new ones, right? I can't learn Spanish so well that I forget how to speak English. That'll never happen.
That's
right?
a good example.
And yet there are ways that we can pair new associations so well that they become automatic. I can learn and immerse myself in Spanish so well that if someone sneaks up behind me and scares me, I scream out in Spanish instead of screaming in English.
Yes.
Right? I have dreams in Spanish, right?
Yep.
It's more default. The inhibitory learning theory is more about exposures can be useful, right? They're still used, but there's a big shift away from the exposures and a big shift onto the response prevention. The response prevention is the medication. The exposures are the practice for the response prevention. The exposures can be useful because they can teach us. We can learn, I can survive having this fear. I can survive being in this kind of situation I was avoiding. I can survive this thought, this uncertainty. I have a lot more strength than I thought. We're ungaslighting this perceived fragility of I can't possibly feel comfortable or move on with my day with this thought existing in my mind. And instead, you're doing all of these exposures to prove that I really do have a choice whether or not to respond to these thoughts. I'll use the word reassuring because this is safe reassuring and therapeutic reassuring. You're reassuring yourself that when I have an intrusive thought or an urge to compulse, when I respond in a skillful way, it greatly increases the chances that my distress dies down and I return to a sense of being comfortable, a sense of clarity, not a sense of certainty, but I gain a sense of clarity around relevance faster. Versus if I compulse, it often increases my anxiety and decreases my sense of clarity. So it's just learning that this is a much more healthy way to respond to these thoughts in general. Instead of trying to get rid of them, again, we're installing that kind of filter system in our brain. We're coming up with and practicing a way of responding to these thoughts by ascribing a relevance to them that becomes so automatic that we basically neutralize any of the relevance or the strength or the pull that these thoughts have over our lives. And it's that perspective and practice that is way more in line with reality and way more, let's say, guaranteeable.
Yeah.
I'll say on the one hand, and on the other hand, in comparing it to the emotion processing theory, there is, just like you were describing, the person 10 years into their situation, there is a really easy way to corrupt and compulsify the ERP through that older model, right? Of I'm going to keep doing these exposures to try to get rid of my anxiety. And when you start to do that, you're compulsing. If I am doing an exposure to try to get rid of my anxiety, if I'm saying if I do this exposure, my anxiety is going to go down and I'll get a sense of certainty after the exposure, I am compulsing. I'm not doing anything that's therapeutic, right? And then suddenly you're using the therapy to really add fuel to the fire, just like any compulsion does. And the therapy is working against itself.
That was such an important breakdown and distinction in terms of why the exposure piece is way less important over the response prevention piece. And the word that comes to mind. So first off, the way that you framed it up with clarity versus certainty was such a wonderful distinction in and of itself. And for those of us in the OCD community who are maybe a little untangled from our intrusive thoughts, because there was a time period where I don't know if I would have known the difference between certainty and clarity, but it's interesting, and it's exactly what you touched on, because I'm not even striving for clarity when I'm doing the response prevention. What I do know, though, and the word control comes to mind here, is where in the old model, it was taking the control away from the sufferer, the individual who was struggling, and putting so much pressure to never have another thought again. That's control out. To your point earlier, your brain is just bubbling up random thoughts, feelings, urges, and sensations. But when you give yourself permission to just focus on how you respond, that's it.
Yeah.
I'm not trying to get a result. I'm not using ERP as a compulsion, because if I do this, then my anxiety will go down. I am just doing this because if I can basically control this piece of it. And I know statistically, based on evidence-based research, that if I do this, there is a chance that I gain some form of clarity. There is a chance that, who knows, maybe my anxiety will go down a little bit, but that's not why I'm doing it. I'm just focused on the response prevention as the piece that I can control. Sure. And I really like that breakdown.
I will say, even though this language seems to kind of go against a lot of OCD kind of schools of thought, there is an alternative way of looking at like what you just said, in that you, with the inhibitory learning theory, where you're kind of learning over time like what works and what doesn't, you can kind of reassure yourself and say, every time that I respond with response prevention, I'm glad afterwards, and and I feel that my and every time that I respond with response prevention, I'm glad afterwards, and the experience generally only lasts, like on average, X amount of minutes or whatever, if I'm very skillful. And every time that I compulse in this situation, I never get a permanent answer, and my distress goes up. So I'm going to choose what has kind of worked on with me a lot in the past, because it does have the greatest odds of returning me to baseline. And I don't think that that's a compulsive thought. I think that that's kind of in line with the newer model of saying, okay, I'm learning over and over that this strategy yields me better return on investment than the other strategy.
So I'm so glad that you said that, because you're a licensed professional, and I feel that you can say that over me. But there's this sort of knowing that it comes with reps, and I think I reflect and I think, wow, it's 2023 now. This started in 2016 for me, and there's just this much deeper understanding of myself, my brain, the OCD. I've just gotten so many reps that to your point, it's just, I know what's going to get me the ROI. Yes. and that clarity. I still to this day, I'm not seeking certainty, but the clarity of like, I think I'm probably straight. I mean, I might not be, but I probably am. I'm probably not a pedophile. I mean, maybe I could be. I probably won't pick up a knife and stab my wife in the kitchen, but I mean, there's a chance. I suppose there's definitely a chance. Like, it's that knowing that has come through the repetition, which is what you're describing.
Yeah, and it reminds me of a point that we haven't quite wrapped up. Is that in terms of that game of whack-a-mole, right? If we're doing that older model and we're saying, I need to do exposure to habituate to this theme, a lot of times, if you do some exposures and you experience any sort of habituation, because OCD is not, there's an actual problem with this one theme, or there really is this uncertainty that's special to this one area, and if you kind of reduce it, then you'll be fine. It really displays how it's just a broken alarm system that's looking for justification, as Dr. Phillipson had coined. It's, so a lot of times if we habituate to one theme, the OCD just shifts to something else. In fact, if you kind of track your like OCD symptoms over time, you wouldn't even notice that you had one theme go away and one theme like come up, because you would still be obsessing and compulsing the same amount. It's
Right.
just the topic has changed. So the topic is the least important point, even though it's the point that everyone wants to focus on, like help me
Right.
with this topic and this theme. It's the least important point of working with OCD. It's the common variables. How do I manage having a sense of dread, having a gut feeling that something's wrong, words popping into my head, either in the form of questions or statement or images or GIFs or what have you.
Right.
How do I tolerate that experience? That's what we're looking to accomplish in therapy.
My therapist said, the other one, not Dr. Abramowitz,
Okay.
but she would say the content will always change. How you respond shouldn't. Meaning, if you, yeah, and that's what you're talking about. And I think I really am glad the way that you broke down the difference in thought process between the old model and the new model, where the old model was very much so like, pick your theme, we're going to drill into it until you're numb to it, versus, hey, the theme doesn't matter at all. It's going to switch on you. Better to learn the how to respond more effectively, so that over the course of your life, as the themes change, you're just, which they inevitably do, you're just responding in the way that gives you the most effective result. And that was just a really important breakdown, I think, for people to understand. Like, your subtype today, I mean, like, for me, one of the big turning points was when in the same week I went from being gay to being a pedophile to being a psychopathic murderer, and then back to being gay. And I was just like, okay, all right, I get the game now. Bring on the ERP. Let's do this shit.
Good. I call those kind of moments helpful hopelessness.
Yeah. Ooh. Yeah. I like that. I'm gonna have to write that down.
Thank you. It also, a similar moment would be kind of realizing once and for all that, like, your therapist doesn't know anything about yourself. And even if they gave their opinion on your theme, even they are just like guessing or whatever. If they're saying, I'm going to treat it as OCD, any of those moments where you realize, damn, like, certainty really is not achievable, and achieving certainty is not going to solve my problems, even if it was achievable. And then being like, okay, so like, bring it on, skills, because this really is the only kind of logical situation, I think is a very helpful thing for people to experience.
Completely agree. So let's bring this full circle here. I also want to be respectful of your time. So when working with people that don't respond well to treatment, knowing the breakdown that you just gave, do you often find that a lot of people you work with are really fixated on habituating going a mile deep on one versus not having the skills? Is there something with the inhibitory learning system? Help navigate that.
I think I actually... and folding in the helpful hopelessness, that's a lot of the retraining, right? Because a lot of folks come in saying therapy should have deleted my OCD symptoms, and it hasn't. Help kind of lobotomize that part. Yeah. And in realizing kind of what is achievable and what isn't, that classic difference between like what is pain and what is suffering, right? Pain is the inevitable. Pain is, going through a divorce or losing your job or getting an injury. Suffering is what we add on to it, right? Suffering is the maladaptive relationship. It's ruminating. It's beating ourselves up. It's anticipating the future, or kind of, thinking about the past and kind of spiraling negative lights. And with OCD, what's helpful to kind of re-educate and reshape is they're looking to get rid of the pain. They're looking to get rid of the inevitable. But what happens when we try to get rid of the pain is we only increase the suffering, right? The pain is kind of more or less indelible. That's a topic for another day, of like, how much can you actually predict the intrusive thoughts to go down? And there is some degree that you might have some influence, but that's a larger conversation. And not one to put all your money into at all. But yeah, re-educating that if you can accept the pain and reduce the suffering, what you will learn is that if you're looking at the overall umbrella of what is causing distress, the pain is maybe 5%. The suffering is the 95%. So if we learn to kind of accept the 5% really skillfully, you do reduce the distress that you're experiencing in your life dramatically, right?
Right.
In good therapy, you should experience a dramatic reduction in anxiety. That can be promised, but it's really important to understand what types of anxiety, right? The stuff that you're adding on to it. So we still kind of predict and promise that your life will increase in quality pretty significantly, but we're very specific in talking about, what you can change and what needs to be accepted. And that's kind of the orientation shift that's really helpful for a lot of people who had gone into the therapy previously with the hopes of my life will get better by getting rid of that 5%, the pain. Then I won't have to add on the 95% that I've been constantly dumping.
So do you see that as one of the biggest reasons why people struggle to respond well to the treatment, is that they're so fixated on getting rid of the pain that...
Yeah.
Okay.
Yeah.
So then how do you teach them to get untangled from that belief system?
It's really kind of things alongside the spiel that I just gave. It's not replacing it with this kind of pessimistic, bleak outlook of, oh, you're going to experience this level of distress forever, and we just need to accept that, right? Because there is a lot of change that is promised. So it's painting the picture that the life that you're really hoping for is pretty closely achievable. You might still have some flare-ups every now and then that are kind of beyond your skill level or that trip you up and things like that. But for the most part, you can develop a filter system to immediately disempower the thoughts that makes the quality of your life very similar to the experience of not having the thoughts at all.
Yeah.
It takes a lot of practice and things like that. But there is that very nice and very achievable outcome that is not that black and white. That is not the I'm going to suffer from unbridled OCD forever, and is not the I'm going to go to therapy. My therapist is going to prescribe these exercises for me that are going to get rid of the OCD, but is predictable, is replicable, it is achievable for anyone, and still does result in absolutely a life worth living that is, well experienced and full of meaning and moments of joy and pleasure and fulfillment.
Yeah. Okay. Because I've been able to achieve that and experience that in my life. So I know it's possible. For me, once I learned that acceptance was the game, it sort of became a game of, I almost feel that the mentalities that you learn in the OCD world, gosh, if we could get it out to the general public,
sure,
we would be a happier society. Yeah. I mean, oh, you missed the 3:00 subway. Well, there's one coming at 3:10. Like it's 10 minutes. Just accept it. There was shit that happened when you were trying to get to the subway. It's a big, busy city. It is what it is. My wife's from New York, so
sure.
we spend our fair amount of time in New York. But yeah, what you're talking about is acceptance. And it is interesting, though. I will say, like, I do think of some of my friends in the OCD space. Cultivating that acceptance can be very, very hard for some people. It can be very challenging and to their detriment. One thing that I'm curious about before we break is you have OCD and then you treat other people with OCD. Do you see... what is the relationship that you have towards, I will call, the big three substances? Like the three most consumed substances in the world are caffeine, alcohol, and nicotine. And then at this point, you might as well throw in cannabis. So that's the top four that are consumed. Like for me, one thing that I'm not very open about this. Cannabis became a crutch for me because it would sort of mask the anxiety and the intrusive thoughts until it didn't. So I don't utilize that substance anymore because for me, the relationship was very unhealthy. Then you've got, like, let's say you're somebody with a healthy relationship with alcohol, no co-occurring substance abuse disorders. Like you can sit down, you can have a couple glasses of wine and that's it for the night. For me, what I've noticed in my journey is that I'm not abstinent. I still drink occasionally, but it feels like it comes with a price.
Sure.
That feels above like, and again, this is just me thinking out loud, but I want your perspective. That feels above average from the person who doesn't have OCD, who wakes up the next day and is like, I feel kind of groggy and like I have a little bit of a wine headache, and I'm kind of over here like, if I have a couple glasses of wine 2 or 3 nights in a row, like things can kind of start to get dark for me.
Oh yeah.
Okay, so
I'll speak to the general, and then I'll speak to myself as someone with OCD. To the general, there's tons of fluctuation, but the experience of initially turning to something like cannabis because it has this like numbing effect, and then it becoming something that increases and exacerbates OCD is something that I've heard a ton.
Okay.
And a lot of people that with OCD they don't even experience that first part. Like it makes them super paranoid and anxious in their mind. I'm kind of a similar way where when I'm feeling like, really skillful and good, like I could have like an amount that is the experience of having a glass of wine, like that kind of dosage. And at first I felt like I needed to almost like relearn the skills to be able to apply them in that state of mind. But now occasionally, like it seems like something that every now and then is a safe enough thing to do. With
it's not
alcohol,
a regular. Oh, sorry. Okay,
that was not a regular thing that that
was with cannabis. Okay, so now we're going to alcohol. Okay.
Yeah, the cannabis thing, like in my personal experience, it's a pretty occasional, like a few times a month and a very low dosage kind of thing.
For sure.
Nicotine, I've never had any experience with, and not a lot of clients that I work with have kind of used it, but the way that I would conceptualize it a lot is in a distress tolerance model. And it can, in some ways, I think, reinforce an association of, if I'm feeling uncomfortable, I need to relieve it. There could be a very compulsive thing around, like, the frequency of use with nicotine, and it could like really atrophy our distress tolerance skills. So that could be something that's useful to consider.
Okay.
And then with alcohol, I very frequently kind of see an association of quantity of alcohol use and how you're feeling the next day. It might be an association that only kicks in after a certain dosage. At least in my personal experience, if I have one like portion of alcohol, one serving of alcohol or something like that, I'm not really going to feel it the next day. But past that point, I think the second or third drink, I think it's almost like a zero-sum game past that point, where I'm just kind of stealing happiness from tomorrow to experience now. And sometimes I'll make that decision. Sometimes I'll say, I'll have, double enjoyment now because I'm with all my friends, and I know that I'm going to have half enjoyment for a few hours tomorrow until I kind of stabilize and stuff like that.
Okay.
It's an informed decision that you can make, but I think it is a very common experience for those of us with OCD.
That the way that you put that was really helpful, because it does feel like I'm sort of, whenever I do go literally past the one drink, like if it's anything past one, I'm stealing joy from tomorrow. For me, that's just what I've come to realize. Yeah.
And you can make that deal sometimes. It's not inherently a bad deal to make, but you should make it with informed consent, knowing exactly what you're doing.
Totally. That was really helpful. I appreciate your perspective on that. So as we can conclude, there were topics that we didn't get to today, but honestly, I feel that there's going to be opportunities for another podcast with you. There's so much more that we could explore. For today, though, could you give my audience one piece of advice that you wish that you would have had at the start of your mental health journey, or a piece of advice that you give your clients that are right at the start of their OCD journey?
I like to use this like catchphrase of no more logs a little bit, where I see a lot of times the OCD as like some smoldering flames, and when we're compulsing, it's not just that the throwing a log on the fire, it might make it look like it smothers for half a second, but not only does it make things more intense, but it takes longer for the fire to burn out, right? We're looking at the inhibitory learning model as this, by response prevention, will speed up the time that I that it takes for me to return to a place where I feel sane and have a sense of clarity, right? You can also conversely view each compulsion as you're throwing a log on the fire, and you're really delaying the amount of time that it's going to take for you to return onto baseline. So I think that that's a very useful thing for people to kind of consider when they're very aware of, should I compulse right now or not? Are you going to let that fire die down and return to a sense where you're a little more confident at making a best guess? Or are you going to try to smother it for half a second and really add fuel to that fire and keep you in this state for a longer period of time?
That is an awesome analogy that I've never heard before.
Thank you.
I like that. And as somebody who likes to build fires, like I'm growing up as a little kid, like I would do bonfires in the backyard. And we were actually just up in the mountains recently, and there was a wood burning fireplace there, and I just went nuts building fires. But if you put the log on wrong, it looks like it's going to smother the fire. But to your point, all it's doing is adding fuel to the fire, and the embers become so much hotter at the base of the fire, and it can just burn so much longer. So I can perfectly picture that analogy. That's great. Fantastic. Yeah. Well, Sam, I have to say this was a very enjoyable conversation, and your wealth of knowledge. I definitely want to bring you on again for further conversations. Are you on social? Where can people connect and find you?
drsamgreenblatt.com. Is my website. My email is sam@drsamgreenblatt.com, and we have an Instagram account. I believe it's called OCD is Treatable.
Okay.
Because unfortunately, a lot of people sometimes give up some hope, but you can check us all out through that.
Perfect. Awesome. Well, I really appreciate you coming on the podcast. Thank you so much for your time.
Yeah, thank you. Total pleasure.
Okay.